Hey, David, thank you for coming in. Just a marvelous background that you have. You're an entrepreneur, you have patents, you worked in the pandemic time as well, and really in a fundamental way to help the country. You have a great educational background, and of course, you're now the chief medical officer for Microsoft and VP of healthcare for Microsoft. And Microsoft is like a 4+ trillion market cap company. So it's like you're the head of medical for an entire country. That's how big Microsoft is. And in addition, you're just an awesome person. So thank you for
Thank you.
coming in and
I
sharing your
appreciate
insight.
that. Thank you, Stephen, for having me. I'm super excited to join you on this conversation. And yeah, my journey has been a little bit of an unusual one. I started out as a clinician, researcher, very interested in understanding why there's so much variation in care. And that led to a product called an evidence-based order set, which eventually became a company or was part of a company that was acquired by Cerner. And so next thing I knew, I'm implementing evidence-based order sets and electronic health records, not just in the US, but globally. And it was an exciting time. But we've seen that quite a progression. Healthcare technology is not just about EHRs anymore. It's about all the technologies that we can envision that not only providers can use, but also consumers and patients. So this is an exciting time, and it's just a fun time as well.
Well, you definitely are a global contributor and you have so much talent and capability. But we're going to go back into the past a bit. So,
Okay.
and that's where we're going to start. And then we're going to sort of do a chronologic kind of step through the different parts of your life to where you are today and the
Okay.
future where things are going. Now, what were two or three inflection points in your life that made this wonderful person you are today? And it could have been when you're 2 or 3, 5 years old, inside, outside school, inside, outside the family. It could have been challenges you had or opportunities. So a first job, it could be anything that really shaped you to who you are.
Yeah, well, thank you. As I reflect on my career, I oftentimes think that there are a lot of things that have happened in my life that kind of have brought me to where I'm at. And it's not necessarily the things that you would think of. I've had some good success in terms of academics. I was getting good grades and good scores. But when I started getting into the more advanced classes and the higher competition, I realized that there are a lot of people that are better at test taking than I was. And when you use that as the parameter for how you might see yourself in the future, you realize, well, you know what, maybe I'm not necessarily going to be the best or the most successful in whatever category. So I just began to start doing things that were, I'd say, a little more atypical. So in undergraduate, one of the things that I did was I said, you know what, I know I want to be a doctor. I want to focus on this, but I also think computers are really fun. This is right around the time that video games were around, and I actually wanted to make video games. So I was a computer science major, and so I did both. I actually was a computer science major and a pre-med. And I remember my advisor telling me at the time that big mistake, because if you want to get to med school, you've got to focus on this. The pre-med, your grades are going to suffer. And to some degree, he was right. I couldn't spend as much time doing all the things to kind of bolster my grades. But I enjoyed it, and I did it because I enjoyed it. Actually, my thesis at the time, this is 1988, was AI in healthcare. So I was doing this at a time when people weren't really necessarily thinking about AI in healthcare. But those are the types of things that I started doing. I just started exploring and doing things that I felt were uh, things I enjoyed. And the more I enjoyed it, the more I realized I was good at it. And I started realizing where I might find some of my strengths that I didn't even realize I had that were outside of, the traditional academic, parameters of test taking and getting, high scores. So I started realizing that was one thing that was particularly interesting. Just pursue your passions. But then the second was that I remember I was invited to speak at this very large forum. It was one of the largest forums I've ever spoken at, and this is when I was a fellow. And people had said, "Oh, David, you know your stuff really well. You'll do great." Well, when I got there, it was it was daunting because the audience was so large and I was so nervous. I could not even focus. I didn't even know the words that were coming out of my mouth. I bombed. And after that, I said, oh, you know what? I'm never going to be a public speaker because I can't do this. And it was one of those things that over time I realized that actually it wasn't as difficult as I thought. And the greatest piece of advice I got was from my advisor. He said, listen, David, you know the stuff better than everyone else. You don't have to tell them every single thing. They just want to learn like three things and be entertained. And ever since then, it kind of calmed me down. And I've pretty much now said, for me, when I do speaking, I'll tell stories and I'll just be a little bit more relaxed. And I found that to be very helpful. So like that was the second thing, just realizing that I actually had a talent around communications. And that sort of translated to this other piece where there were oftentimes very complicated things that were happening, whether it was in healthcare, technology. And I just always found a way to explain it to people that they could understand it. And that ended up becoming quite an important talent because a lot of what you have to do today is just communicating what you're trying to do. So these are kind of things that happened over my career. And I started realizing that they were pretty valuable building blocks for my future.
So I'm going to still go back to the early days. So you indicated that your grades are good and things like that. So
At one point, but then it started, not being as good as everyone else's. And I started realizing, hey, you know what? I'm not necessarily going to be the top in my class and top in whatever test. So that then sort of was a wake up call for me because I realized that that's not necessarily, that gave me the chance and opportunity to do other stuff.
yeah, but so it sounds though that you came from an environment where sort of doing well in school was a good thing to do, and you did well in school, and you were interested in the sciences and the math. And did you have interests in the early days outside of those areas, like in poetry and English and things like that, or really more in the science and tech area?
I think the other thing that I've always had a passion, I've always wanted to be creative. I've always wanted to think out of the box. I've always wanted to look at an issue or a problem or a topic and say, well, what else is there and how else can you look at things? And for me, that ability or that desire to want to address and solve problems in ways that people hadn't thought of was always something that has always I've carried with me because today when I look at problems, oftentimes I say, well, why don't we take a step back and see, are we actually like too deep into this and have we missed the big picture? And sometimes that, reflection on the problems and trying to think differently and take different perspectives and see whether or not you're actually looking at things was something that I very much enjoyed. So things like creative writing, art, music, I've always been very interested and I continue to be in all those areas. I love history. The thing that I love about history most, especially when I go visit places, I love learning about the cultures and what's happened and what's transpired. But I want to understand, like, why did it happen? And not just like the facts, but like what led to these events, and then I truly understand like what could potentially be lessons learned so that we could apply it in the future. So for me, history is about learning. It's about learning from the past and trying to find ways that you can gain insights. And so those are all just, things that as I was going through my coursework, at the time you didn't realize that was your passion. But for me now, I realize that, a lot of it does have to do with how you take the courses or the different types of things that we do and try to get something more out of it.
Yeah, so you're integrating different interests and you're sort of employing early stages of combinatorial thinking and interdisciplinary thinking, right? Because you're curious amongst many different areas. So not only the sciences and in computing and in math and things like that, but you indicated history and music and so on. So you did well enough at school that you enter university, but what was the first university you entered into?
University of Michigan in Ann Arbor. Yes.
University of Michigan. So that's the tie-in with Stephen Jaya in a sense, right?
That's right. Yeah. So Stephen and I were actually neighbors. For those that don't know Stephen is an incredible business person, philanthropist, entrepreneur, and just a really great person in terms of a beautiful heart. And he and I were neighbors. We lived in the same neighborhood. But at the time, when you're kids, you just kind of see each other as someone who you can play tennis with and hang out with and have, grab a snack, but you don't really see yourselves in the future. But he went on to medical school. I went on to medical school. Our paths were, kind of running in parallel. And then, of all things, we met at a conference in the Vatican, like, I don't know, like several decades later. I was at Samsung at the time, chief medical officer. He was head of J&B Medical and doing some amazing things. And we were there, and it was just an amazing time for us to reconnect.
So now, okay, so you're at the University of Michigan at Arbor, and that's where you do your undergrad, and so your undergrad would be focused in the sciences area, but you're also taking computing science, and that's where the advisor was saying, hey, what are you doing? But computing science is such an important part in AI, of course, and you even indicated what your thesis had AI in it back in the 80s, right? So,
Yes.
so you can see the sort of the growth of AI now. Did you go to the same medical school as Stephen Shire or
No, we kind of had our own different paths. I went to Northwestern in Chicago. Was a very traditional experience, medical school, 2 years of book learning and then 2 years of clinical. I didn't really know what I wanted to do at that time, and I chose internal medicine. I thought it gave me the most options. Matched out in UCLA, Cedars-Sinai. So I was out there in California and Los Angeles. I did a lot of, just the traditional clinical learnings. But one thing that did influence my career, which I would love this to be a part of everyone's curriculum, is I did a 1-year fellowship in health services research. And what that was an opportunity for me to express my creativity again, because I was very curious. Why was it when I went to different hospitals and, I was at the VA, Cedars-Sinai, UCLA, the county hospital, we saw such variation in care. And even within the same hospital, we'd see same variation in care relative to the exact same patients coming in. And I always wondered, well, are they getting better care, worse care? Is this something that's warranted, unwarranted? And sure enough, there's a lot of unwarranted variation care. And I said, well, why don't we just do what we know we're taught in medical school, this evidence-based medicine? and it would surprise me because we learned the same things, but then some people would always say, well, you know what, there's the art of medicine. I was like, well, if randomized controlled trials say that we all should be doing it this way, how is there art? It should be science at that moment. Now, the things that we don't necessarily know, I can understand. And so I started focusing on this concept of standardization. And for me, that was a really interesting time because we were just now starting to understand that we could change behavior by providing the right information at the right time. And we could automate that and use tools, electronic tools. And this was the foundation of what just now we refer to as clinical decision support. But at the time, it was called evidence-based guidelines, and people were very interested in it. And I was right there. I was spending a lot of time studying it. And that was what kind of brought me into this whole world of healthcare technology, that curiosity, and also the creativity around trying to build new things. But I'd say the ability right now to measure and to determine ROI is a skill set that everyone should have. Because when you look at a study or somebody presents something, let's say you're an investor, a company comes to you and presents, we've got the greatest product, you have to know how to evaluate that. You have to really know, are they using the right approach? Are the data valid? What would be the next steps? And if you don't really have that basis, you can't really make a judgment on this. And so that's what I've learned. It's not just about the science of healthcare and medicine. It's about, kind of understanding how to evaluate the different types of modalities that are presented to you.
So again, I can see then the roots of the, like the computing science kind of perspective, right? Data driven, and not so much sort of tradition, right? There's this idea in medicine. I did a South by Southwest back in 2018 with a doctor, and in my research for that session, which was on medicine and where it was going, it was surprising to me that like 50% of medicine is kind of just based on sort of ideas that became sort of baked into doing things. It wasn't evidence-based. I thought
Right. Yeah. Well, we sometimes call it expert based, expert opinion. Right. Exactly.
yeah, and so and so you get into these kind of paradigms and things like that that really aren't necessarily correct, right? And it is because you're not using, like you said, studies and things to say, hey, this is the way things are going.
Yeah, and there's a lot of bias. Like when we see a patient, you remember the last patient that you saw or the patient that had some bad outcome, and then you change your practice based on that small subset when the reality is maybe you're not seeing the whole picture.
Yeah, so okay, so we mapped this journey at Northwestern. You're doing all of this kind of clinical work and things like that. Okay, what was the next step after that?
Yeah, so when you match, you don't really know where you're going to go. And I matched out in the West Coast at UCLA Hospital, and then I did my completed my residency at Cedars-Sinai. But at the time, I didn't even know if that's what I wanted to do. Like I wanted to go out. Everyone else is going out to private practice, and I said, well, I actually think I probably need a little more time to incubate what I want to do in my life. So that's when I started doing fellowships. The first was health services research. The second was infectious disease because I was very interested. This is right around the time that AIDS or HIV was becoming sort of a big concern. And I wanted to do something impactful. And that was the area that I thought would be most impactful to become an HIV researcher and AIDS physician. And it was a time in which it exposed me for the first time to my first pandemic. And I've now since then had several experiences, that have given me a lot of understanding in terms of how we can better manage public health and how we can better address these potential pathogens that are out there. But at the time, it was very new, and I think it was new for everybody. We were experiencing something that we'd never seen before, and it was also a time in which I felt like I was making a huge difference. There were times in which patients were coming in, and you know, just being on the front lines of a battle like that was amazing.
So maybe for the audience, because they may not be familiar with sort of kind of the medical journey, you do your education, you do the clinical stuff for your education, you end up then doing fellowships. What does that mean, a fellowship? Is it like an ability to continue research in different areas and receive grants for that? How does that work?
You could do research fellowships, but a lot of the fellowships are clinical. And when you do a clinical fellowship, it's usually 1 to maybe longer in terms of years, in terms of additional training. You are essentially a junior attending. Attendings are the ones who make the decisions in terms of clinical care. So you've got the licensure, you've got the authority to do that. But when you're a fellow, you still report to an attending within that division or within that specialty. And for me, infectious disease was a 2-year fellowship. Clinical, I was on faculty at a bunch of UCLA hospitals and Cedars-Sinai, but as a fellow. And then I afterwards joined I joined UCLA as an associate professor, and I was then taking care of patients in the same context that you would envision any other doctor in an academic teaching institution. I had medical students, residents, fellows, kind of all working with me to manage patients both on the inpatient and ambulatory side. And so that's the traditional career path that most people take. And I would say I was well down that path. But the research that I was doing and all the studies I was showing was that you could actually use evidence-based medicine in a way that would lead to better, more efficient care. And I found myself in a lot of the projects just being running around the hospital trying to inform people. And I said, there's got to be a better, more efficient way. Like a good example was I did this program. It was a randomized control trial to show that we can improve vaccination rates if we just simply had a form that nurses could fill out, and then nurses did the vaccinations. It was like one of the first nurse protocol-driven vaccination programs implemented at the VA. And so I just demonstrated that this works better than just our traditional route of having them see the doctor, significantly better. Well, what happened was, I got this published. And after the study was over, the boxes, I left them there and I left the forms, but because no one was looking over it, the vaccination rates dropped back to normal. And I realized that if you don't have this constant oversight and intervention of, presenting that right information, making sure all the boxes and the forms are all available and current, and educating people, they eventually got pushed to the side and no one paid attention to it. And that's the same thing that I saw again and again. So I said, well, we have to do this in a way that, is workflow compatible, is sustainable, and is something that was highly effective. And that's when I started realizing and pivoting my career towards making technology tools that could be used by people working in an electronic health record and other systems so that they could become much more effective in terms of their decision making.
Okay, so I could see your career arc, right? Fellowships, and then you're working in an academic environment as a professor, in essence, right? Or in the
That's right. Yeah.
academic journey, but then you realize the value of technology and how they can automate these things, because you see things you can implement and then it just gets kind of forgotten and it doesn't get implemented, right?
Right.
So then what was the next step?
Well, what was happening was this product that I had kind of conceived of called an evidence-based order set was something that it turns out was essential for every go live for an electronic health record, because what it did, in addition to standardizing care, is it reduced the amount of time a physician or clinician needs to enter orders into the system. When you see a patient, and let's say you're admitting a patient with community-acquired pneumonia, there's a series of labs that you have to order, a series with blood work, there's chest x-rays, there's antibiotics, there's a whole series of vital signs, you name it. There's a long list of stuff you do. And it takes a while to enter things in manually. You drop down boxes and everything, maybe about like 20 minutes to put it all in. Well, we could reduce that to less than 1 minute just by having a menu and you just check the boxes. That's it. Super easy. And so, of course, if you're a busy doctor, you're admitting patients, you're going to migrate to the menu, to that evidence-based checklist. And so that ended up becoming an essential part. And because of that, I found that this product ended up becoming something that needed to be integrated into every type of system. But it was not just, here's the product, go with it. You actually had to talk to the doctors about, well, what needs to go in the order set? So they need to know what this was. We had to expose them to it. To some degrees, we had to localize it to their formulary, and we had to inform them that, these little things off to the side that showed there was evidence were things that in blue ribbons were important things. So that was very helpful for them to gain adoption. And that's become a big part of even what we see today, even with AI. You can't just expect AI to just solve it. There has to be some discussion with the clinical teams about how this fits into workflow and how people can use it and how they can be more effective.
So this product, this creation of automation, right, for doctors and things like that.
Evidence-based order sets.
Yeah, evidence-based order set.
Yeah.
That was in a company then,
Yeah. So it was one of the products of a company called Zinx Health. Actually, the funny story is this company was owned by Cedars-Sinai. And I remember at the time, Neil Patterson, the late Neil Patterson, CEO of Cerner, now Oracle, but he came in with his group because he wanted to have a meeting with Cedars and he wanted to understand what is it that you have that we could potentially utilize within our system. And I was asked to demo this prototype for him. And I remember thinking to myself, this is a little bit of vaporware because there's really no product behind it. But I showcased what it could look like, how it would integrate using XML into the different systems and all the backend, and how there were SNOMED codes. And he liked it so much, he said, I want to buy the company. Well, there were a lot of other reasons he was interested in, but this was one that he was particularly interested in. And it ended up becoming the flagship product of the company because ultimately it was an essential part of every go live. But that was really kind of what brought me into healthcare technology. It was the fact that I gave a good pitch. Someone said they saw the vision in it and they wanted to move forward with it.
Okay, so the company gets purchased. You go with the company then?
I was there. Yes, I was there with the company. I was actually doing clinical work part-time. But eventually, the amount of work that was required to make this company successful just gobbled up all my time, and eventually I had to stop clinical work.
I see. But you had equity in the company as well,
Well,
or
keep in mind, I'm a fellow at the time at
oh, I
UCLA,
see.
at Cedars-Sinai, and when you're an employee of a hospital, you don't really have all the benefits that you can think of today. But yeah, I mean, it was
I mean, yeah, but it's like at least a good
I got
part.
6 patents out of it.
Yeah, exactly. So,
That's about it.
uh, okay, well, you got recognition anyway. So
That's right.
okay, so what happens is you're with this company, you get patents on it. It's a novel way of doing something. There's definitely value, right? It's kind of the foundation of what you see globally now. And then where did you go from there?
Yeah, so for 10 years, well, maybe closer to 12, or so years, I was implementing EHRs, using this as a primary vehicle. We built out other evidence-based tools, such as evidence-based plans of care, and there were a whole bunch of other types of decision support tools that were being built. So I was deep into the electronic health record workflow for clinicians. But one thing that really was, again, in my mind, I was thinking, well, what else is there? I mean, it seems like, you send a patient home and then they come back and it's like, well, what happened when they were at home? Wasn't there any way for us to be able to better communicate, use the evidence-based medicine for patients and for consumers, give them the same type of information, but maybe in a slightly different format? And so this concept of expanding and doing something a little bit more creative, it wasn't quite in our DNA to do that as a healthcare technology company. But where it was in the DNA were consumer technology companies like Samsung. And so at the time, Samsung approached me and I joined them as their global chief medical officer. And one of the things that I was focused on was building out technologies that consumers and patients could use. So a really good example was cardiac rehab, where I worked very closely with Kaiser Permanente to build out a program where we could change the paradigm of how patients receive cardiac rehab, which was traditionally in a facility where you go 6 weeks, several times a week, and you would ultimately complete this program and get great benefits. But the problem is less than 50% of people were completing the program. It's just too difficult to get people to spend 6 weeks to come in regularly. I mean, people have jobs, they live far away, it costs money, they've got children to take care of. And so about like 40 some percent, 42% of people completed the program. But the problem is we know that if you complete the program, you will save lives. So by complete, the number needed to treat is somewhere between like 7 and 17 patients. So if we can complete the program, we can save lives every time we do this. And so what we realized was we made it too difficult for patients. Can we take the technology and capture the core essence of cardiac rehab and put it on a smartwatch and a smartphone and have that done? And so that's what we did. We took the core components, we brought it onto a smartwatch, and we demonstrate that we could actually improve the completion rate. It went from 40% to 80%. The readmission rate dropped from 11% to 1%. And this was around with 200 or so patients. So we scaled it to 1,200. We saw the exact same results. And now it's being adopted widely across all of Kaiser Permanente. It's like the only digital health solution that I know of that has achieved massive scale. It's over 35,000 patients that have now undergone, and they're still seeing the same results. And it's extremely rewarding because what we have done is we've actually changed the whole paradigm of how we could potentially manage care, leveraging these digital tools. And that was something that I was very proud of to be a part of.
And so, okay, so you're at Samsung, you're the chief medical officer at Samsung, and you have the ability to address it at the consumer side. So you get this really ability to go global as well, right? In a big way.
Absolutely. But the funny thing is, this kind of goes back to the electronic health record. I wanted to take the data from the watch and I wanted to combine it with the EHR data and build a predictive model. Okay, like this is what I was thinking of, like 6, 8 years ago, and I started saying, well, we could try to do it, but we really do need to talk to some of the folks that do this sort of for a living. So I started approaching several companies, and Microsoft was there, and we were talking quite a bit about this. And the challenge I was running at was that this lack of interoperability. So in this concept of interoperability, I started spending a lot more time trying to understand and unpack and how to address this. And Microsoft was trying to do the same thing. So that was the time in which Microsoft approached me and said, "Hey, you know what? You should be joining us. And we're kind of on this exciting journey." And I joined them 6 years ago, and it's been an exciting 6 years ever since then.
Okay, so let's describe some of the things that happened at Microsoft. So you joined Microsoft and just maybe the progression of different projects that you've worked on. And then we'll get into some of the things you're working on now, both inside and affiliated or aligned with Microsoft. And then we'll talk about some of the future where you think AI and diagnostics and some of the tools and the things that I think are really interesting that Microsoft is doing. Okay, so can you highlight some of the key things that
Yeah.
happened with your,
So I joined Microsoft 1 year or a little less than a year before the pandemic hit. So I was just getting my feet under, just trying to get myself my bearings straight and understanding a little bit more about the company. And then of course the pandemic hits. And the first thing that happened was there were people, Microsoft has offices in Wuhan, China, and we had employees there that were sick. And they said, well, you know what? We have a chief medical officer who's an infectious disease doctor. Maybe we should just ask him his opinion. So I remember going on these calls, talking to the team in Wuhan, and I was like, boy, this does not sound good. And we were getting pings from other places literally within the next 24 hours throughout the entire region. And so they said, well, why don't you serve as our coordinator for the pandemic, the response? And I was like, yes, I absolutely want to help and see what, opportunities there are for perhaps, leveraging the prior experiences I've had working at, as an AIDS a doctor and doing other types of pandemic work. And so then all of a sudden it extends to Italy and then very quickly Seattle. And so now all of a sudden the whole company is activated. And when it hit Seattle, there were shutdowns, there were like lockdowns, there were just incredible, an amazing amount of things going on all at the same time. And as every challenge occurred, the company started focusing on how do we address those challenges? How do we work with partners? And so one of the things that I ended up spending my time doing was I started working with organizations like the World Health Organization to help them build out what's called the World Health Data Hub. And I remember working with them and a group called Avanade to build out this platform. Now we were just starting to get this off the ground as the pandemic was starting to move along. And it's still around today and it's continued to grow, but we were there sort of breaking ground on this. And then the CDC, when we started getting the vaccines, they needed to have a data lake to be able to manage all the data. So then I helped work with the team to help build out the CDC's vaccine data lake. And then the next step was, well, we need to get these vaccines into arms of people. And so I started working closely with a lot of the states to get this into as part of the rollouts. And then we started setting up these mass vaccination centers. And the mass vaccination centers needed a technology to be able to do registration and scheduling of appointments, and then taking that data and sending it securely to immunization registries. And so that back office type of stuff that traditionally is done with an EHR, when you move it into these community centers, we didn't have that lightweight capability. So we built out these technologies. And so then I started realizing that we actually need to get into the communities themselves, because a lot of the vaccination rates, especially in underserved and rural communities, was very low. And a lot of that had to do with the fact that there was a lot of concerns, vaccine hesitancy, about science behind the technology, the actual vaccine itself. And there were so many other things that we realized were needed to be done. And so we brought in community organizations, community-based organizations, nonprofit churches, schools. And that really opened my eyes to the fact that healthcare is not about hospitals and clinics. It is about all the stakeholders working together in a coordinated manner, leveraging a common technology that makes things more accessible. And so that has been sort of one of the key lessons learned for me around the pandemic. Pandemic starts subsiding, people start going back to their traditional workflows, but the things that we were focused on were leveraging the key learnings and the technologies from there to try to bolster public health and create a more sustainable system. And then, of course, AI starts coming along. And AI has been around a long time, as you know, Stephen, and there's, I would think of many researchers that have been doing some amazing work, but it was around the time that generative AI just started captivating everyone's attention that we saw some of the work that we had been doing. We'd been doing a lot of work on ambient voice. We said, we could take this generative AI capability and convert this ambient voice into a product and launch it, and with high confidence that it will actually do what we believe it can do. And so then we started realizing that not only could we embrace the technology, but we could embed it into all of our products very quickly. And so for me, that has been an incredible journey, because the AI journey, starting with co-pilots, helping individuals to do their tasks, to now starting to look at how we can build out with the AI, different agents and orchestrating them and creating processes to ensure that it's done responsibly, has been a big part of my career as of today.
So now let's look at, what's on your dashboard of things that you want to implement and, with these different technologies going forward. Let's say that this year, next year, and the near term, and then maybe in the further term, so some specific projects you're working on, both within Microsoft, but also aligned with sort of your interests of making better healthcare.
Yeah, I think my key lesson learned during the pandemic and even before is that no one company can solve this problem. It has to be solved through an ecosystem approach, a collaboration, and an ability for us to be able to use common data infrastructure. That's been sort of my key theme and lesson learned. And so as I've approached every issue, I've come to realize that there are three key things that we need to think about if we want to have AI, we want to maximize the value, and we want people to truly get the value out of AI. The first is we need to understand what are the use cases. And there are use cases today that are low-hanging fruit, specifically around making things more efficient, operationalizing and making a person more efficient, reducing the manual labor of a lot of the administrative burden that's placed on individuals. We can do that immediately. But the thing that I am super excited about is we can use AI to address problems that we thought were impossible to solve. The rising cost of healthcare, access to affordable healthcare, clinician burnout. I mean, these are things that we've said, these are impossible to solve because it requires too much issue. There are too many factors that need to be addressed. And here's what we learned. So we can use AI right now to screen large populations and find the sickest of the sick and bring them to care before they even know that they have disease, before they even know that the disease has progressed. That's extraordinarily important, not just for the patient, but from a cost perspective. 5% of people are responsible for 50% of the overall costs of care. 20% of people are responsible for 80%. But the problem is by the time the 5 and 20% present themselves, it's too late. They've had the heart attack, they've had the stroke, they've had the hip fracture, and those individuals have to be identified months, years before they actually have these conditions. But how do you do that? Well, now we can actually screen using non-invasive techniques. There's many different ways. We can use EKGs to find things. We can use chest x-rays, CTs. But the one that I think is really extraordinary is using the eye. Just a simple eye exam. We actually see the optometrists probably more frequently in general than we see our primary care docs, because it's easy. You need to get your eyes checked. You need a new pair of glasses. And those images that are captured on that machine are now moving to the cloud in a secure manner, and AI can be applied on it. And that's what's happening. So we launched something with several stakeholders called the Alliance for Healthcare from the Eye. It allows us to be able to screen not just for eye disease, but for chronic diseases like diabetic retinopathy, cardiovascular disease, hypertension, preeclampsia, chronic kidney disease, even looking for biomarkers like Alzheimer's, MS, Parkinson's. There's a tremendous amount of research. And so this is one area that's been extremely exciting. So to me, use cases is like one aspect. It's specifically transformative use cases, things that we could not have addressed before. The second, though, is, and the second and third are really tied together. It doesn't matter if people don't use it. And why won't they use it? Two reasons. One, they don't trust it. If they don't trust it, why don't they trust it? Because they don't trust that it was developed right. They don't trust it wasn't tested on the same data sets. They don't trust that, that you've monitored it for drift and all these variables, that there's bias introduced. We do need to do We need to put governance in, we need to put processes. And so this whole concept of responsible AI, and it's not just I'm signing my name to a document, but it's what are you doing to actually monitor at the level of the actual model and potentially now at the level of the agent. And those are the types of things that several organizations have said, we want to do it, but we want to do it efficiently. And so the Trustworthy Responsible AI Network, or TRAIN, is another initiative that I helped launch with several stakeholders, specifically a lot of health systems in the US and then in Europe. And now we're starting to move this to other parts of the world. So that's been extremely rewarding because we're now realizing that AI goes in hand with responsible AI. Okay. The third piece, which we have not necessarily really done as much, but we do need to think about the future. And it ties back to the trust. And that is that people may not trust it because they're afraid. They're afraid they're going to lose their job. We know it's incredibly powerful. And if they look at it and organizations look at it, the immediate response is, oh, this does the same thing that this clinician does, or this technician or this clerk. I'm just going to replace them. Now, in some cases, it may make sense to do that because there's a high cost associated with certain things, but we may be missing the bigger opportunity. And that's the thing that I want people to realize. We have to pause and say, what is it that we can do that we couldn't have done before? So let me give you an example. This was shared to me by one of my work colleagues, and so I can share this in public. He has an uncle who went to an ER. He had severe abdominal pain. And while he's waiting in the ER, he died. And he died because of a burst aneurysm. Now, it turns out that he had a CAT scan done while he was in the ER, and he was waiting. And the CAT scan, before it had burst, it showed that aneurysm, and it was sitting in the queue to be read by the radiologist. Think about this. If we would have replaced that radiologist with AI, this person would have still had the same outcome. But now imagine if we had kept the radiologist there, but we used AI on the front end, and we found that this person, as soon as they got the scan, had a high risk, of a rupture aneurysm, and was immediately brought to the top of the queue. Who knows? We could have had a different outcome. And that's what we're talking about. Augmenting care by using AI with the limited resources that we have. When we have a value-added service, when it's an important service, we don't want to replace resources. We want to augment them because you don't want to replace valuable resources. Now, you may want to replace non-value-added services. So it really comes down to what is the value? If you're just doing administrative work because there's no other mechanism, yes, let's replace that activity. But if it ends up being that we have a very valuable service, let's not replace them, especially if they're limited. Let's augment them. Let's create a 10x, a 100x, a 1000x set of capabilities. To do that, we actually are thinking about a 3-step process. One is education, teaching people about the basics. The second is experiential learning. Give people an opportunity to actually play and use these tools in a secure environment. And the third is proficiency and learning to know, understanding what the workflows are and becoming proficient at it so that we can actually create a jobs program so that AI will create jobs as opposed to take away jobs. And so to me, that's the third category. It's still, I'd say, under development because we're still trying to get the stakeholders together. It's not like one organization. Again, this requires teaching institutions, industry, and organizations that are all working together in a coordinated manner. That would be extraordinary because then we could accelerate the time for adoption. A lot of times when these technological advances occur, many, many years, decades occur before we actually get an entire workforce skilled to be able to do it. If we can accelerate that, that would be fantastic.
Now, how do we ensure, because you indicated that there's differences in care, and whether it's rural, whether it's metropolitan, even between different metropolitan centers, there's the aspect of different kinds of data flows, and are people sort of looking at a commonality of those data flows? Or even data silos that are out there? Are you aware, or are you involved in programs to kind of do some harmonization of all of this to actually address some of the disparity that's occurring? And can you go into some of that work?
Absolutely. This is an incredibly important part of what we do. I oftentimes think of AI as just one side of the coin. It requires data. And the data needs to be harmonized. It needs to be curated. It needs to be annotated. It needs to be organized in ways that can be utilized. And in fact, the analogy I oftentimes use is this like oil that comes out of the ground. A lot of times people say, "Oh, I've got data." I'm like, "Well, you've got crude oil coming out. Maybe you've done a certain level of filtration, but what I need is high octane gas. That's what's going to run in my engine. And that's what the AI needs. To do that, we need a whole series of processes. And then you may find that people have processed the gasoline in different ways across different parts of the country or the world. We need a harmonized manner so that, if I drive my car to your city, I can use your gas. And that to me is what we are trying to accomplish right now. Of course, there's interoperability standards that we are all focused on, but it's adoption of those standards that is the barrier. There's so many, I think people are saying, well, we need more standards. Well, it could benefit from that, but I would argue that we're not even adopting the ones that are out there. So let's figure out ways that we can do a higher level of adoption. And there's many challenges and variables to that. But let's find the use case. Let's figure out what the opportunities are, and let's try to create that harmonized process. Of course, we may be able to use AI. AI might be able to help us in that process of creating harmonized, perhaps taking some unstructured forms of data, these different images that we see, taking the voice, taking the text, the conversations we have, and bringing them into a manner that is already harmonized on the back end. So it didn't require us to kind of go and essentially create a new process for managing and organizing it. Maybe AI ends up becoming a great enabler for this. But these are the types of things that we're all right now on that same journey. We have seen again and again that technology is great, but when it doesn't work in a coordinated, organized, harmonized manner, it's limited in its ability to scale. So we would love to have interoperable, highly scalable data sets that can then be brought together in a privacy-preserving manner so that individuals and organizations can take advantage of it.
Are you working on any programs that are addressing sort of underserved areas and making sure that, they get sort of, frontier, top levels of care and things like that?
Yes, absolutely. So I'll start with one that's happening here in the U.S. There's something called the Rural Health Transformation Initiative, and that is an initiative that and just to give you a perspective, is a lot of investment that's going on in this space. Meaningful use, which was for the electronic health records, was overall $35 billion over 5+ years. That's an incredible amount of money. This rural health transformation is $50 billion in literally less than a month and a half. I mean, it's insane how quickly this is moving. And what we're finding, though, is that they have a set of objectives that they want to meet. They want to increase access to care. They want to apply chronic disease. They want to use technologies in ways that are going to improve care, that are going to create mechanisms for people and organizations that are in rural communities to be able to get a higher quality of care. They have challenges. They don't have enough clinicians. The distance is an issue. The cost is an issue. How do we make care more affordable? All of the things that we know are critical, huge investment. And it may end up being that by investing in rural health and building out this infrastructure, we may be able to help solve some of the bigger problems that we have outside of rural health. That's happening in the US. We're starting to see opportunities throughout multiple countries. They're creating federated learning systems in Europe. We're starting to see opportunities where countries are starting to collaborate in ways that they've never collaborated. This is an incredible time because we're realizing that with technology, we may be able to bring data sets together in some cases, but in other cases, we may be able to leave the data where it resides, so long as it's understandable, and bring the AI models to them. This whole concept of bringing your models to the data, that's the federated process, is something that I think a lot of people have struggled with, but we're starting to see some real traction in that space.
Okay, so we just have a few more minutes, and let's say about 2 to 3 minutes. Let's go into a little bit of the future. I mean, Microsoft has this Microsoft Discovery program or Discovery platform, which is under some kind of pilot right now with potential rollout next year. You got your Microsoft Azure Quantum Elements, or
Yes.
And different people are sort of looking at that. There's an acceleration on the quantum computing side, acceleration on the hyperscalers, that is the cloud providers like Azure, where you're building these huge capabilities with like millions of GPUs and things like that. So you see all of these announcements. So there's really transformation occurring in supercomputing and high performance computing, chip technologies, also in quantum computing, advanced materials, AI machine learning, robotics and automation, biotechnology innovation, also in brain computer interfaces and neurotechnologies and energy and manufacturing. And Microsoft is sitting across all of these. And so what do you think about some of these advances? And you, for example, you have your Majorana 1 chip and you're already in the DARPA, benchmark or these different DARPA initiatives for utility scale. There's only 2 finalists in one of the programs, and that's Microsoft's one of them. So because you're across all of these different areas and the implications to healthcare, so can you just spend a couple of minutes what you think about that?
Yeah. So I'm going to start very high level. When we think of this approach, we start at the foundation, the data, the foundation of even the data centers. Like where are we going to be managing and storing the data? And so, as you're probably well aware, there's been a huge investment in terms of creating data centers that are very cost efficient, that are economically or eco-friendly. So for us, building these eco-friendly, cost-efficient data centers that have high capacity, and then from there, potentially even thinking about how quantum, and all the different types of technologies that are now being developed and tested could be a part of that. So that's, I'll call basic infrastructure that we're starting to rebuild. We're starting to realize that the data sets themselves need to be kind of better organized, curated, and this whole process of how do we create more interoperability, federated learning systems, bringing data sets together, allowing data to reside where it's at, bringing models. That ability to create networks is extremely important. The models themselves are extremely, they're changing, constantly. We had this idea that we were going to use, choose the best of breed large language model. Well, you can see just as of recently, we're starting to say, hey, you know what? Some of these approaches, we could actually break it up into agentic workflows, and we may use different models for different tasks, and that's fine. So now it ends up becoming more about workflow and use of different models that allow us to be able to then be much more effective, but it's all stitched together or orchestrated in a manner that allows for the human to oversee this process. And that is what we need to move towards. It's not about one model doing everything and just kind of forgetting about it. It's like if you were flying an airplane or you're driving a car, you don't need to have yourself looking at every single thing. But what you do want is the technology to look at everything and understand, hey, there's something that's not quite right. I need you to take a look at that. And having that dashboard, having that visibility of what's happening is what we're building. We're starting to build out the governance processes, the tools that allow us to be able to do that so that we can look at it not just from the model level, but even at the agent level. And that's the level of granularity that's going to allow us to be able to become much more effective in terms of deploying this. And then, of course, there's programs, which I just talked about. So we've got the amazing technology, the infrastructure, we've got the capabilities, we've got the AI, but it has to be deployed in ways that people are working together to solve meaningful problems. And that's why these collaboratives are so essential, because if it was just about one stakeholder, we'll never solve the problems. We need to coordinate between providers, payers, pharma, life science, med tech, community-based organizations, teaching institutions, municipalities, governments. Everyone has a role when we talk about health, because it's not just about what happens in a clinic, it's about the health of the individual. And of course, the individual is now going to become the center. We can start moving all this away from the traditional infrastructure, make it highly accessible, affordable, and maybe on your watch, on your patch, on your phone, make the center of healthcare the person. And that would be the ultimate goal. Get everything out of the complicated, expensive, inaccessible infrastructure that we have and make it something that anyone, anywhere can take advantage of.
David, that's really a great, we're at the end of the time. I was going to ask you maybe one more question, but really, we're literally out of time now. So that was a great summation in a sense of what we need to do going forward. David, you have such a wonderful background. You're just a global contributor, an amazing talent, and your work resonates with everybody out there. I really appreciate you coming in and sharing your insights with our audience.
It was such a pleasure. Stephen, you are an amazing person as well. We need to have a separate session just for you.
So, we're going to be seeing each other in different places. So thank you again, David, for coming in.
My pleasure. Thank you.
Thank you for listening to the Brand Called You videocast and podcast, a platform that brings you knowledge, experience, and wisdom of hundreds of successful individuals from around the world. Do visit our website www.tbcy.in to watch and listen to the stories of many more individuals. You can also follow us on YouTube, Facebook, Instagram, and Twitter. Just search for the Brand Called You.